done that.
Minimize this screen and do share screen. Yes.
So who's doing this?
PG resident, Jawaharlal Nehru Medical.
Who's a consultant. Kind some more. Sorry, that's a Thursday. There from Cleveland. You can kindly share yours. Rajiv sir?
Yeah, I'm just doing that one.
Yes, sir.
Seem to be getting it on this. I don't know why. Not getting it.
So the share button and the lower panel, the third button, the share.
So I've done that, but I have two PowerPoints open and only one of them can be seen.
Okay, okay.
So you can again minimize the screen and go back and look at minimize your PowerPoint which you actually want right now. So then maybe later on again we can do share screen for the second PowerPoint.
I think I'll close that second PowerPoint.
Yes,
Yeah,
yes.
maybe. And then we can open that later. Yes, sir.
Now the first one is not seen. Why is that happening?
So you have one PowerPoint minimized on your
I just have one PowerPoint open right now.
Okay, and this is the one we are going with right now, case 456.
Yeah, but then can you see it?
So
you've
no,
not
you
shared.
have not
Can you see it
shared it yet. So you clicked on the share button, right?
Yeah, I did.
No, because you are still not sharing this.
Sir,
Now,
now you're
yes, sir.
yeah.
Yes, sir. Yes, sir. It's come. Perfect.
Okay.
Only full screen. Slideshow mode. Yes, sir. Perfect. Yes, sir.
Okay. So who's doing this?
Yes, sir. Myself, Dr. Krati.
Yeah, go ahead.
Sir, HNE stain section from a skin biopsy shows hyperkeratosis and orthokeratosis. Epidermis appears to be of normal thickness, showing prominent granular layer, along with focal flattening of the retiridges. Dermis is fibrocollagenous, showing dense inflammation in the upper dermis at places reaching up to dermoepidermal junction. Second slide, please. So moving on to the higher power, we can appreciate hyperkeratosis and prominent granular layer. Focal vacuolar degeneration can be seen in the basal layer. Dense inflammation can also be noted in the upper dermis. Sir, next slide, please. On further higher power, we can appreciate that inflammation is comprised of lymphocytes and histiocytes interspersed between collagen bundles, and also there is focal vacuolar degeneration in the basal layer of the epidermis. So next slide, please. Also on higher power, we can appreciate melanophages with pigment incontinence, as it could be because of chronic condition or pruritic condition, and a focus of degraded collagen is also noted. Next slide, please, sir. So this looks like mucin staining, staining the mucin interspersed between the collagen bundles.
I think this was the last slide.
Yes, sir.
So
on the basis of these histological findings, sir, the probable DDs could be, sir, interstitial type of granuloma annulaire, Answer points in favor of this are like presence of lymphohistiocytic infiltrate, presence of degraded collagen, and presence of mucin is the characteristic finding. So apart from that, so lupus erythematosus can be the one, as hyperkeratosis can be seen, focal vacuolar degeneration can be seen, interstitial mucin deposition, and lymphoplasmacytic infiltrate. So apart from that, sir, fixed drug eruption can be also one of the DD. As a lichenoid type of lymphocytic infiltrate is seen along with pigment incontinence with scattered melanophages, along with vacuolar alteration in the epidermis. And sir, we have to rule out infectious etiology as well. In a setting, sir, leprosy is like a very common finding. So, sir, we have to rule out that also.
Good. You did a good analysis. Now let's go through this again. So one thing is that there is a thickened stratum corneum, which almost looks as if it's from the palms of the soles.
Okay.
So this seems to be from acral skin. The other possibility is that this has been rubbed a lot, because this can occur on normal skin if it gets rubbed. As you rightly marked, that there are at places there is a flattening of the rating. Now, what is the pattern? Last time we spoke about the pattern. So what would be the pattern here? Pattern of inflammation.
Sir, it's like band-like pattern.
So band-like is lichenoid.
Exactly, sir.
Okay, so it's one of the, it does give a band-like appearance, but at many places it's also perivascular. So this pattern generally would be referred to as perivascular and interstitial, and also forming an incomplete band at places. So therefore, when you talk about this pattern, lupus erythematosus is out because there's nothing in the deeper dermis. Lupus erythematosus generally is a superficial and deep perivascular and periadnexal lymphocytic infiltrate.
Right, sir.
So also with leprosy, there are no granulomas seen here. So what you see at this power is basically superficial, perivascular, and interstitial lymphocytic infiltrate.
Yes, sir.
At higher power, one thing that you didn't mention was this particular vessel. If you see, there's a lot of fibrin deposit here. The other vessels are normal, but this has fibrin deposit, suggesting that there is some element of stasis involved here. The thick-walled blood vessel is fibrin deposit. It's not
Yes.
vasculitis. So it could be from the leg, which is where this lesion is from. You also notice that there was a little basal cell vacuolization here. And there are extra visited RBCs. The one thing that you missed out was extra visited RBCs. You see a lot of RBC. In fact, even within the what you're calling as basal cell vacuolization, there is basal cell vacuolization, but there are also RBCs within the lower epidermis. So if you put this together, you have perivascular lymphohistiocytic infiltrate. You have a slightly thickened wiry bundles of collagen. At places, it is joining to form a band-like infiltrate. There is no true vasculitis. If you see, there are prominent endothelial cells and there is fibrin deposits here.
Yes, sir.
Without neutrophils and without damage to vessel wall. So this probably indicates some sort of stasis changes. And you have purpura. So this is likely to be some sort of purpura on the leg. Now what this is actually hemocidrin. These are not melanin granules. These are hemocidrin granules, and this is the stain for iron. So this positivity shows hemocidrin. This is not mucin. I shall show you how mucin looks later. Mucin appears as very stringy material. This is hemocidrin. So putting it all together, the diagnosis is pigmented purpuric dermatosis, or also known as lichenoid purpura or Schamberg's disease. This occurs on the leg. So it is an inflammatory purpura, but not a vasculitic purpura. If you just look at it again, the pattern here would be on acral skin, you have a perivascular and interstitial, almost band-like infiltrate of lymphocytes predominantly. There is fair amount of extravasated RBCs, and you have fibrin deposits without vasculitis. And then you have pigment which could be melanin or could be hemosiderin. One way of identifying it, unfortunately, this slide doesn't show it, is if you use the low power, if you use the fine adjustment, hemosiderin is refractile.
Exactly.
Whereas melanin is not. And this is the pulse iron stain for hemosiderin. So the final diagnosis is Schamberg's disease here. So the diagnosis made, the pattern is perivascular and interstitial superficial lymphocytic infiltrate at places almost forming a band line. That's why the term lichenoid purpura is used. And the diagnosis made by the, either in the early cases you get extravasated RBCs, in the late cases you may get only hemosiderin, or you can get a combination of the two. Okay, any questions on this?
Oh, sir.
Okay, so let's go to case 5.
Okay.
Sorry, sir. So there is just one question. What is the significance of lymphocytic vasculitis?
Lymphocytic vasculitis is not a very well defined entity. So, every inflammatory disease does show perivascular lymphocytic infiltrates. So, if you get damage to the blood vessel wall, demonstrable damage
Okay.
with predominantly lymphocytes, then that is sometimes referred to as lymphocytic vasculitis, and that may be sometimes seen in a few conditions like pityriasis lichenoides, that is pleva. It can sometimes be seen even in herpes infections. So herpes simplex or herpes zoster, if you see in the dermis, if you have a dense lymphocytic infiltrate, you might get some damage to the blood vessels by the lymphocytes. But
Okay.
when we talk about vasculitis, we are generally talking about neutrophils being the
main
vector cells and
predominant.
not lymphocytes.
Okay. Okay, sir. Thank you.
Sir, can I start, sir?
Yeah, please.
Section studied from skin biopsy shows epidermis and dermis, which is unremarkable, and epidermis is unremarkable, and there is a thin Grenz zone, and dermis shows some perivascular and periadnexal inflammatory infiltrates. Next slide, sir. There is a Grenz zone, which is there is a sparing of the inflammatory infiltrates in the Grenz zone, and the adnexal, perivascular inflammatory infiltrates are composed of lymphocytes. Next slide, sir. Here there is a periadnexal structures, periadnexal inflammatory infiltrates composed of lymphocytes and histiocytes. Next slide.
Yeah, I think that was all.
Yes, sir. It is borderline leprosy because of these features. And I feel in lepromatous leprosy, there will be diffuse inflammatory infiltrates with foamy macrophages and all. And in tuberculoid leprosy, there will be granulomas. So I have given us it as borderline lepromatous leprosy.
Okay. So this is actually what is described as an indeterminate pattern of leprosy, because you don't really see granulomas. It's only a lymphocytic infiltrate. So if you were to analyze this, as you said, the epidermis is unremarkable. What you see is, now if you look at the pattern again, it's very sparse to moderately dense, superficial and deep, perivascular, and very predominantly or very selectively very adnexal. Now the adnexa include hair follicles, arrector pili muscles, eccrine glands and nerves. So if you see here, these are all eccrine glands, and surrounding them you have these lymphocytic infiltrates. So it's very subtle actually. There's hardly anything seen, very sparse infiltrate. You also have a few lymphocytes within the basal layer of the distal eccrine duct. This is the acrosyringium. So this is the distal part of the dermal duct, which is going on to form the acrosyringium. Sparse perivascular infiltrate. Again, sparse perivascular lymphocytic infiltrate here. And here amongst the eccrine glands, surrounding them, you have these lymphocytic. So there's no real granuloma form. So the pattern here is superficial and deep perivascular, periadnexal, and periadnexal. If you see a nerve here, then of course you are very sure that this is leprosy, because very few conditions involve the nerve, inflammatory cells damaging the nerve. So this is a very difficult to diagnose. You need to have good clinical correlation. There are no granulomas, so you cannot really make a diagnosis of determinate leprosy. What you can consider is, especially if the clinical findings are suggestive, you can talk about indeterminate leprosy, because you have very selective involvement of the adnexal structures. Now, if you look at the specificity of adnexal structure involvement, nerve involvement is the most specific. Involvement of the arrector pili muscle, for example, here there is no infiltration, but if this were to be infiltrated, then that also is highly suggestive of leprosy. And then last of all is the eccrine glands and eccrine ducts. So here you will have to make a diagnosis of indeterminate leprosy. Now, what are the findings? Normal epidermis, sparse to moderately dense superficial and deep perivascular, periadnexal, and perineural infiltrates. In this case, of course, we could not see the nerve. Few lymphocytes in distal eccrine ducts, and no granuloma. So without a granuloma, it's difficult to make a definitive diagnosis of leprosy. There are, of course, no foamy histiocytes here to think of lepromatous leprosy. Now, this finding is typically seen in the condition known as indeterminate leprosy. It's called indeterminate because there are no granulomas and the immunity of the patient is not yet determined and therefore indeterminate. Once the immunity gets determined, the patient would either present with paucibacillary, that is tuberculoid or borderline tuberculoid, or multibacillary, which is borderline lepromatous or lepromatous leprosy. But such cases are usually seen as ill-defined macules, which may be hypopigmented or mildly erythematous, commonly seen in children on the face, buttocks, etc., and cannot be classified as determinate leprosy. The natural course of these lesions is that in many cases, they just settle by themselves. In some of them, they go on to form what is called determinate leprosy, which we can recognize with the development of granulomas or foamy histiocytes. And then they become a very well-defined lesion of leprosy. Now, this histology can also be seen in determinate leprosy in certain cases. You have a condition or you have a classification known as maculoanesthetic leprosy, where you have flat patches which are anesthetic, not raised plaques. So if you biopsy these flat lesions would often show this sort of a picture without granulomas. Even BT Hansen's, which clinically are definitely leprosy, may show this sort of an indeterminate picture. And when you treat leprosy, once the patient has received the full course of multi-drug therapy, in the course of events, either old lesions or he may even develop a few new lesions. And if you biopsy them, they don't show granulomas, but they show this sort of a picture. So when you see this picture, you need a good clinical correlation. It could be indeterminate leprosy or it could be either of these forms of leprosy, either treated or untreated leprosy, which is flat in nature. Okay, any questions on that?
No, sir, we don't have any questions from the attendee.
Okay, so let's go to the next. Case 6.
So this is an H&E section from skin biopsy showing surface epidermis and dermis. The epidermis appears to be normal in morphology and the papillary dermis shows scattered mononuclear inflammatory cells, mainly lymphocytes. Sir, can we move on to the next slide? The reticular dermis shows mild edematous changes along with perivascular condensation of mixed inflammatory cells mainly showing lymphocytes and eosinophils, along with sparse inflammatory cells in the interstitial dermis. Few areas also shows extravasated erythrocytes. So can we move on to the next? So here we can see perivascular condensation of mononuclear cells, perivascular condensation of lymphocytes and eosinophils, along with edematous changes in the reticular dermis.
So what would
So
be
my
your-
probable, sir, I have few differentials. First is
Yeah.
for urticaria. Sir, in urticaria, usually in the early lesions, it shows neutrophilic and eosinophilic perivascular condensation of inflammatory cells. But as the lesion ages, it can become lymphocyte predominant. So second differential is arthropode bite reaction. So because of the perivascular mixed inflammatory infiltrates, although, sir, I could not appreciate any spongiotic changes in the epidermis. So third differential I have is leukocytoclastic vasculitis. So because, sir, in this, we can see that mixed inflammatory infiltrates are present. Although, sir, it shows fibrinoid necrosis and neutrophilic, fragmented neutrophils, neutrophilic nuclei, which could not be appreciated. Answer fourth is allergic dermatitis. Sir, in which also we see perivascular inflammatory infiltrates, although, sir, the spongiotic changes could not be appreciated.
Very good. So you have had these differential diagnosis. So we'll again go through the findings. So you have epidermis, which is, you can say, normal or slightly acanthotic. There is no spongiosis seen. You have a superficial and mid perivascular moderately dense, sparse to moderately dense perivascular lymphocytic infiltrate, and also with a lot of eosinophils. You also have a few cells which are scattered interstitially. Now, if you see this, you did notice this extravasated RBCs. These are away from the inflammatory process. So that is where your vasculitis really doesn't come into the picture, because if at all, this would be associated with the blood vessels and surrounding the blood vessels. So this could be traumatic. It could be also part of the inflammatory process where the blood vessels themselves don't seem to be damaged. So now there's one more after this, I think. Yes. If you see here, eosinophils are in plenty. There aren't any neutrophils, or even if there are very few. So predominantly, this is a infiltrate with eosinophils. So the two diagnoses that you mentioned, insect bite reaction or arthropod assault reaction and allergic contact dermatitis, is quite possible. Now, considering allergic contact dermatitis, as you said, there are no epidermal changes. Primarily, allergic contact dermatitis is an epidermal reaction pattern where you get spongiosis. So that is less likely. Also, finding so many eosinophils in an allergic contact dermatitis is not very common. You may get it, but it's not very common. So insect bite remains a strong possibility. In insect bites, the epidermal changes can be very varied. You can get it something like this, where there are no epidermal changes. You can get spongiosis. You can get intraepidermal vesicular formation, and you can even get ballooning. So depending on the type of insect which has caused the problem, depending on the depth at which the insect has caused the problem, you will get different epidermal changes. So insect bite reaction is definitely possible. The other thing that you can think of is a drug reaction, because sometimes drug reactions also show a lot of eosinophils. So this was an insect bite reaction. So you have enunciated this very well. So allergic contact dermatitis, as you said, you expect spongiosis. Bullous pemphigoid sometimes can present like this in what is called a pre-bullous pemphigoid. There, of course, the eosinophils will also be in great numbers closer to the epidermis. And in a fully developed lesion, there will be a subepidermal blister. A drug reaction can be there, in which again epidermal changes may be seen in addition. So most likely, this is an insect bite reaction. The best diagnosis here, if you didn't have the clinical findings, would be an insect bite reaction. So good.
Sir, I have a question, sir.
Yeah.
Sir, are we ruling out urticaria in this slide because we cannot see any
Sorry, I
neutrophil?
did. Yeah. Now, urticaria, I forgot. That was your first differential diagnosis. Now, urticaria usually has a combination of neutrophils and eosinophils. That's number one. Secondly, the number of eosinophils are very sparse. So the number of eosinophils that you see here are quite a few. In urticaria, you really have to scan the section, and you may be lucky if you can see a few eosinophils. So theoretically, yes, urticaria is possible where predominantly you get eosinophils, but in urticaria, you would also expect neutrophils to be present. And sometimes you can also see a fair number of mast cells. So urticaria, I would not keep as the first diagnosis here. In urticaria, also the epidermis would be absolutely normal. Here, you could say it's normal, but there is a little bit of acanthosis here. So the first diagnosis here would still be insect bite reaction. Then, of course, you need to correlate clinically because finally what we are doing is a subjective evaluation. We haven't really, there are no criteria to say that so many eosinophils means urticaria and so many means drug reaction or so many means insect bite. But in general, this is the, if you see the density of eosinophils, urticaria is very minimal. Urticaria also has a superficial and deep component generally. So does insect bite. I have not shown you the deeper part here. So urticaria will be very minimal. Insect bites can be variable. You can get minimal to huge amounts of eosinophils. Bullous pemphigoid or the pemphigoid group can also give a large number of eosinophils. And drug reactions, which can also be variable. So depending on the type of disease, the density of eosinophils would vary. I hope that answers your question.
Yes, sir. Thank you, sir.
Okay, so we are done with this. I think we'll go to the.
Yes, sir.
Just give me a minute because I have to open the next one.
Yes, sir. Sure. Sir.
Can you see it?
Yes, sir. We can see it. Slideshow mode.
Yeah.
Yes, sir.
Yeah.
We can.
Case 7.
So, this image of the, shall I start, sir?
Yeah, please.
This image of the skin biopsy shows lamellated hyperkeratosis, and this is a low pass section where we can appreciate the lamellated hyperkeratosis and wedge-shaped focal wedge-shaped hypergranulosis. The epidermis shows acanthosis, and in this part we can see sawtoothing of the rete and interface changes like dense band-like infiltration, and we can also appreciate the follicular pattern of the lymphocytic infiltration, and the mid dermis and the superficial dermis appears relatively normal with mild perivascular inflammatory cell infiltration. So can we move to higher power image shows lamellated hyperkeratosis and wedge-shaped hypergranulosis. Mild acanthosis can also be seen, and here we can see an apoptotic body, which is also called as civet body or colloid body, and we can appreciate the interface changes like basal cell degeneration, and there is a dense band like mononuclear cell infiltration, which is predominantly of lymphocytes. Next, sir. Here we can see the same part but we have moved down. Here we can also see the mild acanthosis and interface changes like basal cell degeneration and perivascular lymphocytic infiltration, perivascular mononuclear cell infiltration, predominantly lymphocytes. We can also appreciate some dilated blood vessels. So next, sir.
Okay. I think this was the last.
Okay, sir. So my impression is that it is an interface dermatitis, which includes which is of lichenoid type, and my diagnosis is lichen planus. And other differential diagnoses are graft versus host disease, where there will be basal cell vaccination and scattered apoptotic keratinocytes and satellite cell necrosis. And the lymphocytic infiltration is variable in GVHD. And other differential diagnosis is drug-induced lichenoid eruptions, where there is parakeratosis. And parakeratosis rules out lichen planus. There is no parakeratosis here, so we can think it of lichen planus. And the other differential diagnosis is ashy dermatosis, where there will be patchy infiltration of the lymphocytes. So I think it is interface dermatitis, lichenoid type, and lichen planus.
Very good. So you got it correctly. So this is lichenoid. So the pattern, if you see, is interface lichenoid, and the prototype of this is lichen planus. You get broad epidermal acanthosis with irregular jagged rete, the so-called sawtooth. You get focal hypergranulosis. You get a very thick, compact orthokeratotic stratum corneum. So as you said, parakeratosis generally does not occur in lichen planus. Of course, there are exceptions. For example, if you have an excoriated lesion, you might get parakeratosis, or a traumatized lesion might give parakeratosis. But generally, no. On the other hand, as you mentioned, the differential diagnosis of drug-induced lichenoid eruptions, that has to the differences between a drug-induced lichenoid and lichen planus, classical lichen planus, would be that you would get parakeratosis, you would get many apoptotic cells which would be scattered all along the thickness of the epidermis, and more often than not, you can also get eosinophils in the dermal infiltrate. Whereas lichen planus, you don't get eosinophils generally. Also, a drug-induced lichenoid reaction may show a little bit of spongiosis, unlike lichen planus. GVHD, yes, can look very similar. That also shows hypergranulosis. So there you need a very good clinicopathological correlation, because early GVHD does look lichenoid. Even clinically, you can get lichen planus-like papules. So there one has to have a good clinical history of a transplant happening, which would give rise to GVHD. The next one you mentioned was what?
Ashy dermatosis.
Yeah, now this is not ashy dermatosis, because in ashy dermatosis, you get a lot of pigmentation. The infiltrate is very sparse. You don't usually get a lichenoid infiltrate. You often get very vascular. It can rarely be dense. But what is striking in ashy dermatosis is the pigment incontinence in the papillary dermis. So lots of pigment. Here you hardly see any melanophages there, and that is why it's not known as ashy dermatosis, because a lot of pigment in the papillary dermis gives rise to the ashy gray color of the skin because of a Tyndall effect. So this is lichen planus, and the pattern is lichenoid interface. Now lichen comes from the word lichen is actually, lichens are there are organisms which grow on rocks, and you can use the term both clinically as well as histologically. So when you use this histologically, we are talking about this band-like lichenoid pattern. When you use it clinically, we are talking about these lesions. And this is lichen. So this is supposed to resemble this. So you have flat top violaceous colored papules, which have this whitish striae. So this is typical lichen planus. So lichenoid means resembling lichens clinically, or microscopically resembling lichen planus. So in which case you're talking about a lichenoid infiltrate. Now, what exactly is a lichenoid infiltrate? A lichenoid infiltrate is an infiltrate which is present only in the papillary dermis, technically. So if you see these blood vessels, these are the subpapillary. The first day I showed you the diagram of the blood vessels in the skin. You have the superficial plexus and the deep plexus. So this infiltrate is restricted to the papillary dermis. And this is very important. This shows this is the lower end. Now what has happened is that because of the infiltrate, the papillary dermis, which normally would be just that thick, has now got expanded and become extremely thick. but all this infiltrate is within the papillary dermis and causes damage to the basal cell. So this is a combination of the dermis and the epidermis. Interface dermatitis always has the interface, which is the junction between the basal layer and the papillary dermis, that is involved. And for that, there are two components, the epidermal component and the dermal component. So, as I said, band-like infiltrate of lymphocyte, you may get a few histiocytes. The infiltrate is restricted to the expanded papillary dermis. Interface changes may be present in the interface lichenoid type of dermatitis, but sometimes you can just get a band-like infiltrate without interface changes. Then you can also get focal lichenoid infiltrates with or without granulomas. So that forms a different pattern, which is focal lichenoid dermatitis. So this is your typical lichenoid infiltrate. This is your focal lichenoid infiltrate. If you see, there are just two dermal papillae which are expanded with this infiltrate, which is lymphocytes with histiocytes. So this is lichen nitidus. So what are the effects of lichenoid infiltrate? So if you see the effect on the epidermis, you can either get epidermal hyperplasia or you can get epidermal atrophy, depending on the type of disease that you're dealing with. You can get interface dermatitis, which includes basal cell vacuolization, individually necrotic keratinocytes or so-called colloid bodies, basement membrane thickening, etc. Other changes that you can get are ATP of keratinocytes and cells within the epidermis, that is infiltration of the epidermis with lymphocytes, sometimes even with other cells like Langerhans cells. So this is, if you see typical lichen planus, you have a lichenoid infiltrate, you have irregular hyperplasia, you have wedge-shaped hypergranulosis. So this is where you get hyperplasia. So lichen planus generally, at least in its early stages, is hyperplastic, the epidermis. On the other hand, you can get a very thin epidermis. This is atrophy. You see how thin it has become, and you get a lot of melanophages. So this is very late lesion. So this could be a late lesion of lichen planus, or it could also be ashidermatosis late lesion. So this is what you would get in ashidermatosis. Lots of melanophages. Of course, you won't get such a thin epidermis, but in a very late lichen planus lesion, you can get extreme atrophy, or you can also get this sort of atrophy in lupus erythematosus. Then you can get interface changes. So these are necrotic keratinocytes or colloid bodies, some basal cell vacuolization, a few lymphocytes, which then is referred to as satellite cell necrosis. So this is what is satellite cell necrosis. It's not specific for GBH. It can occur in any interface changes. And then what are the effects on the dermis? The infiltrate would expand the papillary dermis. And once the infiltrate slowly regresses, you can get papillary dermal fibrosis. You can get thin fibrillary collagen, or you can get thick wiry bundles of collagen. You can sometimes get sclerosis of the papillary dermis. You can get a variable density of inflammatory infiltrates, and clinically you get a condition called sclerotic atrophy. So if you see here, the epidermis now has started flattening. There is still interface changes, and how wide the papillary dermis has become. See, this is the plexus of blood vessels. So this is the superficial plexus. This is the papillary dermis. The infiltrate has expanded it and has now started regressing. So the density of the infiltrate is becoming less. Over a period of time, the infiltrate goes away, the collagen becomes thickened, and you start getting lymphocytes which are scattered between the collagen, very sparse perivascular lymphocytic infiltrate. So the earlier band-like lichenoid infiltrate has now been reduced to a sparse perivascular and interstitial infiltrate. And in a very late stage, this is what happens. The entire papillary dermis. So you can imagine this was expanded so much, the entire infiltrate has gone, and this has left behind a scar. So this is a scar of the papillary dermis. You can see these vertically oriented blood vessels. This is the reticular dermis. So this was an lichenoid infiltrate, which only affected the papillary dermis, expanded it, and caused it to develop a scar. Now, if this is a elastic tissue stain. So if you see, the entire papillary dermis is devoid of elastic tissue. The elastic tissue is normal in the reticular dermis. This again shows that your damage in lichenoid infiltrates or in lichen planus is restricted to the papillary dermis. So what are the diseases that you get with lichenoid infiltrates? You can get interface dermatitis, which you have already spoken about, lichen planus, pleva, pityriasis lichenoides chronica, erythema multiforme, fixed drug eruption, lichen striatus, and graft versus host disease. There are some diseases which sometimes show interface. For example, one of the cases that we saw earlier, the first case, the case number 4, which was lichenoid or pigmented purpura, that did show a little interface change. There was some basal cell vacuolization, but that doesn't typically come under lichenoid or interface dermatitis because that is not a consistent feature. So also in lichen sclerosis and atropicus, you can get basal cell vacuolization or interface changes. Also in mycosis fungoides, sometimes you can get interface changes. Then band-like infiltrates which accompany pre-malignant conditions. So Bowen's disease, Paget's disease, porokeratosis, all of them can show band-like infiltrates. They usually do not show interface changes, but there is a lichenoid infiltrate. Then you have focally lichenoid infiltrates, lichen nitidus, lichen scrofulosaurum, micropapillar sarcoidosis. So both of these will show small granulomas, and lichen nitidus like polymorphous like eruption. So all of these, the pattern here would be focal lichenoid dermatitis, which could be granulomatous or just lymphocytic. And then you get pseudo-lichenoid infiltrates. I'm calling it pseudo because in conditions like leprosy, TB, chromoblastomycosis, etc., mastocytosis, even Langerhans cell histiocytosis, you can get band of infiltrate. But this band technically involves the reticular dermis, and therefore it is not, technically speaking, a real lichenoid infiltrate. It is an infiltrate which has assumed a band-like pattern in the reticular dermis. Then we spoke about lichenoid eruptions, usually because of drugs. So clinically and histologically can resemble lichen planus, maybe more dermatitic with a little spongiosis, parakeratosis, and can show variable interface changes and lichenoid infiltrates. So both drugs which are systemic as well as topical contact can give rise to these lichenoid infiltrates. Histologically, you will get variable epidermal hyperplasia, many necrotic keratinocytes. Often you will get parakeratosis and eosinophils in the dermal infiltrate. This is one example where you had a photolichenoid dermatitis. So this is from the face because you can see a large number of sebaceous glands. If you see the epidermis, it is irregular, and focally there is interface change and a lichenoid infiltrate, which is lymphocytic, melanophages, and lots of scattered individually necrotic or colloid bodies at all levels, and also a confluent parakeratotic scale, which you don't get in lichen planus. So many colloid bodies, lots of melanophages, and a lymphocytic lichenoid infiltrate. So this is a photolichenoid drug eruption. Then you can get lichenoid infiltrates as clues to neoplasia. As I said, Bowen's disease, Paget's disease, melanocytic lesions, halo nevus, resolving melanoma can also show lichenoid infiltrates, and porokeratosis. You see here, any diagnosis is a very straightforward diagnosis. Anybody?
Looks like Paget's.
Yes, this is Paget's disease. And this was extramammary Paget's disease. So you have this band-like infiltrate here. Of course, this is very typical, but at low power, this is not low power, this is a little medium power. At low power, what strikes your eye is the lichenoid infiltrate, this melanophages, with a broad epidermal hyperplasia and this collection of cells in the lower part of the epidermis, but which also move into the upper part and sometimes can even go into the stratum corneum. So these are extramammary Paget's. These are your Paget cells. Then you can get focal lichenoid infiltrates. As I said, these are the conditions where you get. So here, if you see, there are small granulomas in the papillary dermis. You also have a granuloma in the reticular dermis. So this is lichen scrofulosaurum. can get small lichenoid granulomas, focal lichenoid granulomatous dermatitis. You can get it in the dermal papillae, you can get it in the papillary dermis. You also have granulomas deeper down, and this is lichen scrofulosaurum, which is a type of a tuberculate associated with systemic TB infection. So lichen planus is the prototype of a lichenoid dermatitis. It is also a part of the group of interface dermatitis. So interface can be vacuolar or can be lichenoid, get band-like infiltrates, and these sometimes it's also a clue to epithelial premalignancies. Okay, any questions on this?
No, sir, we can move ahead. We'll take it as we end other questions.
Okay.
Shall I start it, sir?
Yeah.
Okay. Histopathological section from skin biopsy on low power shows epidermal atrophy with a flattening of rete ridges and with basals speculation, thickening of basement membrane, and thickened papillary dermis with perivascular lymphocytic infiltration. Higher power, sir. On higher power, we see the thinning of epidermis with a thick vacuolar degeneration of basal vacuolar degeneration with pigmentary incontinency and inflammatory infiltration in dermis, mainly lymphocytic infiltration. Next slide, sir. Here also we see the melanin pigment incontinency and inflammatory infiltration in dipdermis. Next slide. Here we see the thickening of papillary dermis with inflammatory infiltration, and there is increased mucin and increased lymphocyte and plasma cells. So basically, it is a discoid lupus erythematosus.
Yeah, good. So this is what you said. Now, what is the pattern? Primary pattern here is superficial and deep perivascular and periadnexal lymphocytic infiltrate, epidermal thinning with interface changes. Now here, unlike lichen planus, you do not have a lichenoid infiltrate. You just get basal cell vacuolization, which is vacuolar type with many colloid bodies and scatter of melanophages close to the epidermis. So if you see here, there is no lichenoid infiltrate. It is just perivascular, but which is superficial and deep, and also involves the adnexal structures. Lots of colloid bodies here at the dermoepidermal junction. The epidermis is thinned out. In a long-standing case, you can get thickening of the basement membrane, which is very specific for lupus erythematosus and dermatomyositis. This is mucin. So compare this with the bluish hemosiderin that we saw on special stain. So this is on HNE. And of course, this is a lot of mucin, and this is what you get. This you don't get in the papillary, but you get it in the reticular dermis. So this is the mid dermis, where you get a moderately dense perivascular lymphocytic infiltrate with lots of mucin. So this was cutaneous lupus erythematosus. So a few things about LE. Longer the duration of the lesion, more likely that the specific findings are present. So therefore, if you biopsy a butterfly rash of acute systemic LE, you might not get many findings at all because it has been there for a very few days. On the other hand, discoid lupus erythematosus would have been there for months together, and you will get all the typical findings, including thickening of the basal of the basement membrane. Now, in general, LE is a lymphocytic inflammation of the skin. So most of the cells that you see in LE, inflammatory cells, are lymphocytes. However, early lesions, acute lesions, often have neutrophilic infiltrate. So also bullous LE. There is an clinical presentation of lupus erythematosus, which is called bullous lupus erythematosus, in which you get blisters. In this, you get neutrophils. You get collections of neutrophils in the subepidermal blister, which is a manifestation of acute cutaneous LE. So if you look at the histopathology, you look at the pattern of inflammation. So it's superficial and deep usually. You can even get involvement of the subcutaneous tissue when it is known as lupus profundus or lupus paniculitis, and then the differential diagnosis there is with subcutaneous paniculitis like T-cell lymphoma. The epidermal changes show thinning, so there is atrophy. As you get hyperplasia or acanthosis in lichen planus, in lupus you get atrophy. You get basal cell vacuolization, you get colloid bodies. In the dermis, you get melanophages and you get mucin. That is very typically seen in LE. And if you have involvement of the subcutis, and the differential diagnosis would be other conditions with interface dermatitis. Dermatomyositis looks very similar to lupus erythematosus, and sometimes you can't differentiate between the two. In general, the infiltrate in dermatomyositis is very sparse as compared to lupus, but the mucin can be similarly seen in both. So the pattern of inflammation would be vacuolar interface with basal cell vacuolization, individually necrotic keratinocytes at the dermoepidermal junction seen as colloid bodies, smudging of the dermoepidermal junction, and thickening of the basement membrane, which you don't see in early cases, you see in very long-standing, well-established cases. So this, as you see, is basal cell vacuolization with marked atrophy and a predominantly lymphocytic infiltrate in the papillary dermis. You can get dilated follicular infundibula with keratin plugs. So this is a thickened basement membrane. If you see here, this pink that you see here, this is a colloid body, and below that is a thick basement membrane. And below that are the melanophages and the lymphocytic infiltrates. If you use PS, you can see that there is a thickened basement membrane. Then sometimes you can get uncommon epidermal changes in which there are no changes. That epidermis is normal, but you get a superficial and deep perivascular lymphocytic and perivascular periadnexal lymphocytic infiltrate. This is known as humid LE. So the differential diagnosis here would be, if you read some books, they describe it as the 5 L's. So basically, lymphocytic infiltrate of the skin has a lot of differential diagnosis. Lupus erythematosus, that is tumid LE, where no epidermal changes are there. Jessner's lymphocytic infiltrate, polymorphous light eruption, pseudolymphoma or lymphocytoma cutis, and lymphoma. All of them will have these nodular infiltrates of lymphocytes in the dermis. Then parakeratosis, not usually seen, but sometimes you can get in LE. The differential would be a drug reaction, like in lichenoid reactions, where you get parakeratosis. Lupus-like drug reactions can also occur, or interface drug reactions can occur, in which parakeratosis is not uncommon. The numerous necrotic keratinocytes scattered throughout the epidermis, as in erythema multiforme. Confluent basal cell vacuolization with subepidermal clefts or blisters. So this is bullous LE. And sometimes you can get confluent epidermal necrosis, as you get in Stevens-Johnson syndrome or toxic epidermal necrolysis. So there is an entity known as TEN-like lupus erythematosus. It is actually lupus erythematosus, but clinically it looks very much like toxic epidermal necrolysis. Dermal changes would be superficial and deep perivascular periadnexal lymphocytic infiltrates, neutrophils in early lesions, in acute LE, and in the subepidermal blister in bullous LE, upper dermal edema, extravasated erythrocytes, telangiectasis. In a later stage, you will get upper dermal fibrosis and sclerosis with melanophages. Mucin, this is also something which is quite, you can't say specific, but quite suggestive of LE. And mucin is seen on HNE as stringy bluish material between separated collagens. You have seen that, how it looks. So this is, if you see here, melanophages here, and a lot of mucin. All this is mucin. So stringy material between collagen bundles. You don't need a special stain. You can see it on HN. And then you have lupus profundus, where you have subcutaneous involvement. It's not very common, but it presents with deep erythematous nodules which leave behind depressed scars. Clinical response to anti-malarials is very good. As a presentation, it's primarily a lobular lymphocytic paniculitis, with very often you get lymphocytic nuclear dust. You can get plasma cells, but no atypical cells. Because if you start seeing atypical cells, if you start seeing rimming of the adipocytes with these atypical cells, then you need to consider the differential diagnosis of a subcutaneous panniculitis like T-cell lymphoma. Okay, case 9.
Yes, sir. The H&E stain section from skin biopsy shows unremarkable epidermis, and on this scanner view, we can see that there is dense, moderate to dense inflammatory infiltrate in the perivascular as well as in the dermal area. So the next
Hello, can you hear
slide,
me?
please.
Yes, sir.
Yeah. No, I can't hear the speaker. That is it.
Yeah,
There was some voice break.
yeah, voice is breaking, Dr. Mansi. Can you repeat
Hello.
that again, what you were saying?
Yes. Hello.
Yeah,
Can
yeah.
you hear me now?
Yeah, we can hear you.
Yeah. Uh, the H&E stain section from skin biopsy shows on scanner view. Should I repeat the scanner view or go ahead?
No, you go to this part.
Okay. Sir, on this part, we see that there is dense perivascular. There is dense perivascular inflammatory infiltrate involving small-sized capillary venules, and there is dense inflammation in the dermal area also. There is interstitial infiltrate of inflammatory infiltrate that is also seen. The next slide. In this slide, we see that the capillaries have become prominent because of deposition of fibrin and neutrophilic infiltrate in the walls. We can see many degenerated neutrophils and mast cells, lymphocyte plasma cells, suggestive of nuclear dust. So these features are suggestive of, along with many extravasated RBCs or few extravasated RBCs. These features are consistent with leukocytoclastic vasculitis.
Okay. Any differentials?
So differentials will be all the small vessel vasculitis, like IgM, IgG vasculitis, IgA vasculitis.
But they're all leukocytoclastic vasculitis. So all of them are similar. So that histologically you can't differentiate between them.
Yes, sir.
So really speaking, there is hardly any differential here. The only thing, if you do not get clear-cut vasculitis with fibrin deposits, one of the differential would be the neutrophilic dermatosis like sweet syndrome, where also you can get a lot of neutrophils and neutrophilic dust scattered in the reticular dermis, but there you get a lot of papillary dermal edema. So here what is striking is the pink fibrin deposit in the blood vessels, lots of extravasate RBCs, very vascular. So this is angiocentric. So all these infiltrates are angiocentric as well as interstitial and consist predominantly of neutrophils. You can see the blood vessel walls which are damaged and have fibrin, and interstitially you get neutrophils and a lot of leukocytoclasia. So that is neutrophilic nuclear dust. So that is why this is called leukocytoclastic vasculitis. So this is true leukocytoclastic vasculitis. So these are the histological findings. Generally, it's this. Sometimes eosinophils may be seen, especially in urticarial vasculitis and drug-induced vasculitis. So depending on the size that you get affected, what we deal with in the skin generally is only this small vessel vasculitis, that is IgA vasculitis, cryoglobulinic vasculitis, hypercomplementemic urticarial vasculitis. So which generally involves the capillary and the post-capillary venules. You can also get ANCA-associated small vessel vasculitis as microscopic polyangiitis, granulomatosis with polyangiitis, that is what used to be known as, what was the syndrome that this used to denote? Anybody? So Wegener's, it was called Wegener's granulomatosis, and then you had the Church-Strauss granulomatosis, which is eosinophilic. So these are all ANCA associated, and then you have medium-sized polyarthritis nodosa, Kawasaki's disease, and large vessel, which is giant cell arthritis and Takayasu. So we generally don't see this in the skin. What we see are all these small vessel vasculitis, and sometimes we also get ANCA associated vasculitis. So this is the classification which was revised in 2012. So large vessel, medium vessel, and small vessel. So small vessel, further many different groups. So you had this ANCA associated, so which included Wegener's, Church-Strauss, microscopic polyangiitis. You had immune complex associated, where you had anti-GBM disease, cryoglobulinemic, IgA vasculitis, that is henox-online purpura, and hypocomplementemic urticarial vasculitis, which often is associated with systemic lupus erythematosus or other autoimmune diseases. Then variable vessel vasculitis, in this Behçet's disease is included. Single organ vasculitis, which is what dermatologists generally see, cutaneous leukocytoclastic angiitis. Then vasculitis with systemic disease, so lupus, rheumatoid, sarcoid can all give rise to vasculitis. And with other conditions like malignancy, drugs, syphilis associated aortitis, hepatitis B and C associated vasculitis. So these can be the etiology, but histologically, you cannot make a diagnosis of all these etiologies unless you do other investigation. So as a pathologist, what you can say is that this is a small vessel leukocytoclastic vasculitis. So the clinician then has to go back and check, depending on the organ involvement, depending on the other associated laboratory findings like ANCA antibodies, etc., IgA deposits in the skin. He has to make a diagnosis of which type of vasculitis it is. So the job of the pathologist is to confirm that it is a vasculitis, it is a vascular injury, which is inflammatory in nature. Okay, let's go to the next case.
This section shows the subcutaneous tissue only, in which we can see there is sheet of mature adipocytes lined by thin fibrous septae, and there is a band of widened, broadened fibrous septa is present in between, which shows in so next part, in this section, we can see there is mild inflammation present in the fibrous septa, which is more marked at the junction of the septa and the lobule junction, and there is very minimal fat necrosis present, and here we can also see, sir, there is any hyper. Sir, this is the classical case of erythema nodosum, in which we can also see a non-enlarged histiocytes collection which form a radial or slit-like cleft, and here their neutrophils will also be collected, and and sir, there will be infiltration of neutrophils, eosinophils, and plasma lymphocytes in the septal. There will be septal inflammation, and in this is the classical case of erythema nodosum. Other differentials can be if there is granuloma, palisaded granulomas associated, for example, like in deep granuloma annulare, but where there we will see increased mucin production forming a feathery appearance, and we can also other differentials are necrobiosis lipodica, where we can see necrobiosis, and there can also be necrobiotic xanthogranulomatous infection, where we'll also see increased number of foamy macrophages and cholesterol clefts present, and there will also be necrobiosis present. And if sclerosing disorder is present, like in morphia, we'll see the thickened collagen and altered collagen present. Sir, these are the differentials.
Good, very good. So primarily this is classic erythema nodosum. The pattern is septal paniculitis. By itself, the fat lobules are hardly involved. What is involved is the thickened fibrous septate, which get infiltrated in the initial stage with neutrophils. Then later on, you have lymphocytes and histiocytes, and in the end, you get small collections of histiocytes with some giant cells, what are known as radial granulomas of Miescher. So clinically, these present as tender nodules, which are evanescent. They generally clear within about 3 to 6 weeks, often associated with fever or streptococcal infection. And there is a whole host of etiologies for erythema nodosum. So erythema nodosum is just a clinical and clinico-pathological presentation, which has to be worked up to find out what the etiology is. So patterns in paniculitis would be mainly depending on the location of the inflammation as septal and lobular, and of course sometimes you get mixed. There is a spillover into the other compartment, and you can also look at the morphology. So when you have a predominantly lobular inflammation, whether it is granulomatous, whether it is suppurative, whether it is lipophagic, whether it is necrotic, etc. So diagrammatically, this is how it's represented. This is septal paniculitis. The prototype, so only the septae are inflamed, the lobules are unaffected, and you can get it with vasculitis, without vasculitis. So without vasculitis, erythema nodosum is the prototype. But as she described, morphia, necrobacillus lipoidica, and even nephrogenic fibrosing dermopathy can be differential diagnosis where you get involvement of the septae of the subcutaneous fat, which they become extremely widened, thickened, fibrotic, etc. Then you can get it with vasculitis. So septal involvement with vasculitis, you can get small vessel vasculitis, you can get septic vasculitis, that is infective vasculitis, livedoid vasculitis or vasculopathies. Or you can even get large vessel involvement like thrombophlebitis or periarteritis nodosa within the thickened septate. So erythema nodosum is the commonest of paniculitis, more common in women, more frequently observed during second through fourth decades. Numerous causes. You get tender erythematous cutaneous nodules, usually over the pretibial areas, but you can get them on the forearms, you can even get them on the trunk. In late stage, they acquire a bruise-like appearance. It takes between 3 to 6 weeks for it to subside. And that's why it's also initially called, it used to be known as erythema contusiforme. Can be associated with a wide variety of systemic disorders, which you need to investigate, and may be accompanied by fever, arthralgias, and malaise. And this is clinically what it looks like typically. So this is the prototype of septal paniculitis. Early stage will show edematous septae with neutrophils. In a developed stage, you will get thickened fibrotic septae with histiocytes and the radial granulomas of Miescher. And a very late stage, you will get fibrosis of the septae with obliteration of fat lobules and some angioplasia. So this would be early evolving erythema nodosum. You see how thick the fibrous septae are, and you get foci of neutrophils. This is a well-developed erythema nodosum with very thick fibrous septae, and focally you have histiocytes. And in the late stage, you get angioplasia and gradual fibrosis of the subcutaneous fat. You can get angioplasia within the thickened fibrous septate. Okay, case 11.
We just had a question here. So
Yeah.
can we get epithelioid granuloma in the septae and occasional eosinophils in erythema nodosum?
You can. You can. It doesn't really change the diagnosis.
Okay.
But if you're finding epithelioid granulomas in the lobules, then the diagnosis becomes erythema indurate. And that very often is associated with tuberculosis.
Okay.
But you can get it in the septae also. Usually you don't get very well formed granulomas. What you get are these histiocytes which may have a radial collection.
Okay. Thank you, sir. So we can go ahead.
Shall I start? Good evening, everyone. In this slide, H&E stain section shows low power view of skin biopsy which consists of epidermis and dermis. Hyperkeratosis is appreciated. There is presence of suprabasal acantholysis in the whole of the epidermis with presence of dissociated acantholytic cells. The basal cell layer is intact, forming tombstone appearance. Dermis shows mild superficial perivascular infiltrates. So next slide, please. In high power view, we can appreciate acantholytic cells in the suprabasal region. So next slide, please. In this, dyskeratosis and parakeratosis is appreciated in the subcorneum region. Next slide, please, sir.
This is the last slide.
No, there is
There is one more?
another slide.
Oh.
Sir, here we can see acantholytic cells and coprons and grains. So on the basis of histological features, we can make DDs. Number one is Darier's disease, which has suprabasal acantholysis and coprons and grains. Haley disease can be also the differential, but in Haley disease, there is a brick wall appearance, which is not appreciated in these slides. So my third diagnosis, DD can be Grover's disease, and fourth is pemphigus vulgaris.
Okay. So of the whole lot, which do you think is more likely here?
Darier's disease.
This is actually Haley disease. So if you see, the pattern is intraepidermal suprabasal clefting, but you also have incomplete acantholysis. So this is actually the dilapidated brick wall, what you're saying. There aren't really any corons or grains over here. What you have here is parakeratosis and a crust, and suprabasal acantholysis. There are irregular, incomplete acantholysis, which involves almost the entire thickness of the epidermis. If you see here, this is the dilapidated brick wall appearance. And here you do have a few necrotic keratinocytes. You have parakeratosis. So this is a crust. You can get villi formation. So this is a villus which is formed, lined by basal cells. So this is Haley disease. As you said, all these 4 differential diagnoses can be there: pemphigus, Darier's disease, Grover's disease. So the pattern is intraepidermal vesicular acantholytic dermatosis with suprabasal cleft formation, villi formation. There is an extensive incomplete acantholysis, giving rise to a dilapidated brick wall appearance. So DDs would be pemphigus. Pemphigus usually will have a single intraepidermal suprabasal cleft or vesicles with a single row of intact basal cells, row of tombstones appearance. Darier's, which also falls under the differential of dyskeratotic acantholysis. You get focal disease, suprabasal clefts, dyskeratotic cells. Warty dyskeratoma can also look like this, which is a cup-shaped cystic lesion. You mentioned Grover's. Grover's has many histological patterns. You can get spongiotic, you can get acantholytic, you can get combined. So yes, Grover's also can form a differential diagnosis here. We generally don't see Grover's in India that commonly. For some reason, we don't really see Grover's in India. So this is typical pemphigus vulgaris. You see that very little acantholysis. There is a clear split, which is suprabasal, and you have a single row of cells giving rise to that row of tombstone appearance. This is Darier's disease, where you get epidermal hyperplasia. You get small clefts, a few acantholytic cells, and these are the corons, and these are the grains. So the large dyskeratotic cells, these are the corons, which usually occur in the granular layer. And then you have parakeratosis, which is called grains. So this is known as dyskeratotic acantholysis. Clinically, of course, Darier's disease is a warty papule. It is not vesicular clinically. Histologically, it does show suprabasal clefts. So these are the corons, and these are what are described as parakeratotic grains. Okay, case 12.
So, the HNA skin section of the skin biopsy shows the dermis, epidermis and the dermis. Here we can see the epidermis is thinned out as well as denuded at places. So on scanner we can see there is histocytic infiltrate in the superficial dermis, like papillary dermis, and also a lymphocytic aggregate into the deeper dermis as well. So moving on to the next slide, sir. So here we can appreciate that there is multinucleated giant cells, many are there, and that lymphohistiocytic infiltrate. There is no prominent areas of necrosis are seen. This is it, sir. So on higher magnification, we can just appreciate the multinucleated giant cells as well as the lymphocytes and the histiocytes collection. So this is kind of giving the impression of granulomatous kind of lesion, giving us the differentials of leprosy or tubercular granuloma. And third one will be sarcoidosis, as there is no prominent area of necrosis is seen. It can also be a case of deep fungal infection. These are my duties.
Okay, good. So primarily, if you, as you described, we have nodular dermatitis. So
Nodular
you see
dermatitis.
nodules. There
Yes,
is a nodule
nodular
here, there is a nodule here, and granulomatous as a subset, because you can make out that these nodules are made up of histiocytes with giant cells. Here, of course, there are fair number of eosinophils. Lymphocytes. So the epidermis is variable. There is thinning out here, but there is also hyperplasia here. So that really rules out leprosy, because in leprosy you will have generally a flat epidermis. The other thing is, in leprosy you don't get granulomas which are very restricted like this. The granulomas would generally follow adnexal structures. So you would get involvement of the eccrine glands, you would get involvement of the nerves. It will be superficial and deep, etc. Here there are just two large nodules which are seen. Here, interestingly, there are two artifacts. So one is this, of course, knife mark, which indicates a blunt microtome knife. And the second one is this. Do you know what this artifact is called?
It's a Venetian artifact.
Yes, Venetian blinds artifact. So this is, I mean, of course, it doesn't really mean much, but you do get this artifact whenever there are collections of cells, and when there is a vibration of the cutting apparatus, the microtome knife vibrates in the microtome. So this causes this particular artifact. So you have the Langerhans giant cells, and you have a fair number of lymphocytes. So sarcoidosis is less likely. Also, sarcoidosis, generally you don't get epidermal changes. So going by that, the best diagnosis here would be cutaneous TB. And this indeed was lupus vulgaris, which is a form of plaque type of TB. So, okay, so that was the last slide. So a few take-home messages: pattern analysis and algorithmic diagnosis, along with good clinico-pathological correlation, can help in making specific diagnosis in most cases. One disease can show different patterns, and different diseases can show a similar pattern. It doesn't matter, you can follow one pattern right up to its end, you can still come to a diagnosis. Some diseases have fairly specific findings that can clinch the diagnosis. So a reasonable DD can be generated even if a specific diagnosis cannot be rendered. And with that DD, the clinician can correlate with the clinical findings and come to the best possible diagnosis. Okay, so I think we come to the end. Any questions on this?
So we have two questions. So we will take the first one, that is significance of orthokeratosis and basket weave hyperkeratosis.
No, significant where?
Sir, I Don't know whether it was really asked in relation. Jayashree, if you can type the question again. So there is another question. We can go to that how to identify early stages of mycosis fungoides. Identify early stages of mycosis fungoides.
Early stage, you mean patch stage?
Yes, sir.
Okay, so patch stage mycosis fungoides, the typical pattern is psoriasiform hyperplasia, superficial perivascular lymphocytic infiltrates, which can become interstitial and focally lichenoid. And more importantly is the epidermotropic lymphocytes. So you have these lymphocytes which sometimes can be large and atypical, which are typically seen in the basal layer, what is known as tagging along the basal layer. These are haloid lymphocytes. Yesterday I showed you a slide, I think.
First day, yeah. Yeah.
Yeah, the first day I showed you a slide of mycosis fungoides. So that is how you think in terms of mycosis fungoides. The only thing is that one should not overcall it, because this sort of epidermotropic lymphocytes with haloid lymphocytes can be seen in many other diseases which are not mycosis fungoides. For example, vitiligo can give rise to that. Lichen sclerosis can give rise to that. Sometimes pigmented purpuras can give rise to that. So pityriasis lichenoides can give rise to that. So one has to be very careful in giving a definitive diagnosis of patch stage mycosis fungoides, because one thing is that prognosis wise, it never behaves like a lymphoma. So you don't really treat it like a lymphoma. You treat it like any other inflammatory skin disease. So whether it is really justified in calling it a lymphoma, that is the first question. So I personally try not to call it lymphoma. We have a good term for it. We call it parapsoriasis. There are different forms of parapsoriasis which in some cases go on to develop frank mycosis fungoides. So that is one diagnosis can be used. But of course, sometimes you can't help calling it patch stage mycosis fungoides, in which case you could do that. But these are the general findings that are used, that is epidermotropic lymphocytes and a psoriasiform lichenoid pattern. That is the one that, and of course, if you start getting a lot of atypia, then you can make a diagnosis more easily. But the problem is early patch stage mycosis fungoides is that you don't get atypical lymphocytes. So it behaves and it looks like an inflammatory disease.
Okay. Okay, sir. I think with that we have covered all the questions. If any of our students who are live with us have any questions, you can ask us. So I think, sir, we have covered everything. We would really like to thank you and extend our gratitude on behalf of all our students and all our attendees for an excellent talk and simplifying these diseases, and for the lovely images that you shared with us. Thank you so much. And the evolution of the disease, when it comes from the early stages to the scarring stage and all, that we really enjoyed the talk, sir. Thank you so much. Thank you, all our students.
It's a pleasure being with you.
Thank you, sir.
Thank you,
So
sir.
thank you.